my name is Dawn Edge. I'm a Professor of Mental Health and Inclusivity at the University of Manchester. And I'd like to introduce my colleague, Dr. Liz
Hi,
Camacho.
I'm Dr. Liz Camacho. I'm a health economist based at the University of Manchester, and mental health is one of my key research areas.
Okay. So I'll tell you a little bit about my research. So the research I do is generally into inequalities, but with a particular focus on inequalities that affect racialized and minoritized communities, and in particular within that, people from African and Caribbean backgrounds. So currently, I am the chief investigator for a National Institute of Health Research funded project, a randomized controlled trial, to evaluate the clinical and cost effectiveness of culturally adapted family intervention, or CAFI for short, which is a psychosocial intervention that's been co-produced with people with lived experience, service users as their family members from sub-Saharan African and Caribbean backgrounds, alongside health professionals and advocates and community members. And within my research, it's very much team research. So we have psychiatrists, psychologists, mental health nurses. We have people who are experts in implementation science and process evaluation, and we have health economists. So that's one of the reasons why I thought it'd be really good. Of course, statisticians, but I thought it'd be really interesting to talk to Liz about her role on a project like this. So say a bit more about what you would do, Liz.
Yeah. So I guess it's not the same with that. But related. So some of the work that I kind of do is around perinatal mental health, and one of my projects that I'm leading on at the minute is looking around screening for perinatal mental health problems. And the current NICE guidelines are very kind of vague and open to interpretation. So it's saying things like that healthcare professionals should consider asking questions. And one of the things in that is that's very open to kind of, to the biases and that kind of preconceptions of how people are actually feeling. So one of the things that my work's doing is kind of looking at kind of something a bit more kind of systematic, so we're not kind of have this bias that can come in. So it's kind of thinking, so where do those biases exist, and what sorts of things can we do to address them, and then what are the cost and health implications of that?
Okay. So it's really interesting to hear you say that you're leading this piece of research, because typically I think people assume that methodological specialists like yourself are part of the team, but actually don't get to lead research. So do you want to say a little bit more about your journey to leading research?
Yeah, so that, and I think you're definitely right there on this. Typically us methodologists, we kind of sit at the back of the bus and just kind of go along for the ride and do our little numbers bit. But this was so it's an area that I'm kind of really interested in researching anyway. But it was kind of an opportunity that I saw. So MHR put a call out for researching mental health in the north of England, because they'd identified that the mental health need was actually very high in the north of England, but actually the amount of research funding going to the north of England didn't reflect that. So they put a call out specifically for research in the north of England in mental health. So I had seen a study that had already been done. So, we've already been led by that multidisciplinary team like you spoke about, Dawn, and just kind of, well, so what can I do with that data that's already been collected? So trying to use it that kind of bit more efficiently. So then I kind of came up with an idea that kind of focused on the economic side, but used that information that had already been collected.
Oh, that's great. So at what stage are you at in that process? Can you give us any insights yet?
So analysis is done, but no, insights are still embargoed.
Okay. But great. So you managed to get it funded, and the work is pretty much complete. Just analysis and writing up now. So that's fantastic.
Thank you.
Well done, you. Okay. And so just thinking back on my own career, some of the biggest challenges I've had in wanting to do research with diverse communities and marginalized communities is the sense I've actually been told that my research ideas were too niche, that because it focused on a quite a narrow portion of the population, albeit with high needs, it probably wouldn't get funded. And I wondered whether you'd had any similar conversations with people that even unintentionally could have dissuaded you from doing the kind of work that you're interested in.
That's really interesting, and actually quite, you know, disappointing to hear that that's the kind of feedback that you got, that, you know, it's too niche, and you know, I think that's a real shame. And I think that's one of the so not kind of, not that it's too niche, but a feedback that I get quite a lot when looking at perinatal health, when you're kind of looking at anything that's related to maternal mental health. The feedback I've had a lot of time is, yeah, but what about the dads? But what about the dads? And I do think that is really important to consider that as well. But I think sometimes I kind of think, you know, I think it is really important to consider both. But I suppose, you know, with that historic underfunding of research in women's health, you know, where's that coming from?
And it's a very similar thing in terms of research into particularly ethnic disparities in health. And you know, you would have thought, well, hope now post COVID, where people have seen where that can lead, that chronic under, not just underfunding, but that kind of not thinking through what this might mean, and you know, the inequalities. So I've said before, you know, to people that I'm fascinated, and I'm intrigued by why other people aren't equally fascinated by the fact that the NHS was set up specifically to eradicate health inequalities. And all these years on, what we've had certainly in the last decade is inequalities are widening again. And people, you know, people's life expectancy is shortening. And further north you go, and the poorer people are, that is more the case. There's definitely a north-south divide. So it's intriguing to me that people are now kind of coming back to that again, you know, with Marmot and so on. But that it's not been there kind of threaded through the way people think about the way services are delivered and the way we do research into that. So that's fascinating to me, and we've seen how that's played out in terms of who died and who became really unwell during COVID, haven't we? And but even then, there was a tendency, I thought, with a lot of the messages that were going out that were kind of blaming people. So you know, it was people's fault that they had poor health, that they had chronic illnesses, that there were ethnic minorities, and you know, it was somehow there was a bit of blaming there going on, rather than say, hang on a minute, we have had a system for decades that was designed to get rid of these kind of disparities. So why is this happening, and why are poor, not just poor black and brown people, but poor white people dying in bigger numbers than those who've got money, and then doing something about that. So let's hope that Boris is leveling up, and things like the Marmot piloting that we've got one in Greater Manchester will shed some light on some of this and change the landscape for good. Sorry, I interrupted you.
Yeah, no, I was just going to say, no, I absolutely kind of, that blame thing was really palpable at the time, and I thought a real shame that was kind of the messaging that, and you know, who that came from, but it's definitely kind of seems to be the messaging that the mainstream media kind of ran with there, which I think, you know, just serves to set things back further. And I think similarly, with the Marmot food, that, you know, kind of almost in parallel with the Ockenden review of maternity services. I mean, that's had some pretty shocking things come out. And I think, you know, one of the things, so just to bring it back to my research on perinatal mental health, is one of the things that it kind of said. So, you know, so there's been a lot of work done by organisations such as Birthright, you know, and they've looked at this 5 times more campaign where black women are 5 times more likely to die in childbirth compared to white women. And one of that, they also included perinatal mental health in that. And then again, it just feeds back into, you know, the question that I was kind of saying that I've been looking at, is that, you know, around mental health as well, and perinatal mental health, there's disparities in who is being asked about their perinatal mental health on the grounds of race. So there is a lot of that inequalities.
There is, and that links back. So actually, my PhD was in perinatal mental health, and but what was intriguing is when I asked black women about why, about their experiences of services and about their perceptions of mental health and mental health care, and the extent to which they would use mental health services, because that was one of the things that came out. So I did a mixed method study, and out of the quantitative bit, which was both black and white women, it was really clear that black women were much less likely to be referred to mental health services, and when they did get referred, they would get referred into the more specialist end, the more coercive end of mental health services, not being seen by GP and psychologists and so on, which is where the white counterparts were. But what was really interesting is when you looked at the research, the reason I started doing it was because nobody else had. So a lot of the research around ethnicity and mental health focused either on South Asian women and perinatal mental health and Black men and psychosis. And there wasn't a great deal else in between. A little bit about Irish people in depression, Irish men in depression in particular, linked to alcoholism. But, you know, so many people are missing from these conversations about inequalities. So we still know really little about people from East Asia, from Chinese people, Japanese people, and Vietnamese people. We know very little about them. And there is still that tendency when we're looking at South Asians to agglomerate whole groups of people with vastly different demographics, and we don't really understand some of the nuances in terms of help seeking and so on. So I just think that, you know, there is things are changing, things are improving. We are now seeing more meaningful types of research looking at health inequalities. I think we've still got a way to go, partly because certainly some of the work that I do, when you're wanting to find out from people about their experiences of services to help to understand why they don't reach services or services don't reach them. You know, what are the barriers to actually receiving perinatal care? What are the barriers to having the screening earlier on? And certainly some of the things women were telling me about, actually they do go to clinics, but people don't always ask them the questions. And also interestingly, I thought women who I was talking to them about perinatal depression, what they do was to link their experience of physical health care during pregnancy and childbirth and having really poor experiences of care, and saying, well, if they couldn't take care of me physically, how can I trust them to take care of my emotional, psychological health? Yeah, so I know you can't, I know your results are embargoed, but I'm really intrigued to think about how that plays out, you know, in terms of what kind of services we deliver, you know, how we recreate services that people actually want to use and help them.
And I think this kind of parity between mental health and physical health, I think that's kind of something, you're talking about kind of getting funding for mental health research. And I think that is something that's probably improved generally. So I think kind of, you know, historically, I think there was much more, you know, everything was geared up to cancer studies, essentially. And then gradually more and more weight has been given to the importance of mental health studies. So have you found that? I mean, that's just my perception of it.
I think it's getting there. I think we're still a long way to go because we had a very low base, and then the tendency then is to do particular kinds of to fund particular kinds of studies, which aren't necessarily going to give you the information about the why behind the numbers. You know, why is it that services are there but people don't use them in the way that they're designed? And some of that is because they're not designed to meet the needs of people, you know, across the board, particularly people who are or maybe on low income, people who have mental health challenges, people who've got cognitive impairment. The whole range of people for whom mental health services are still quite, and physical health services indeed, are really still quite difficult to access. And we need to flip the script, I think, and think about how we can engage people rather than seeing them as being non-engagers. You know, it needs to be the other way around, isn't it? By times meeting needs.
Yeah, so, and I think there has been a change in language around that, which that's one of the things I'm quite pleased to see. You know, instead of the hard to reach groups, you know, that's been starting to be phased out, that phrase, and it's kind of like, it's not that the groups are hard to reach, they're underserved because we're not getting to them. And I think that's been an example of a positive change in the use of language around that.
Yeah, and that, I think that reflects, again, this is something to which MHR have been at the forefront around PPIE, so patient to public involvement and engagement. But I'm just wondering your take on this, because I've noticed that recently I've seen grant applications that are really well written in terms of the PPIE. But actually, when you look at the thing as a whole, it looks as though what they've got are people who are very good at writing PPIE, and not necessarily that it's integral to the research. And I don't know whether that you have an experience of that.
So I think that's kind of something from, you know, some of the work that I do kind of sitting on the funding panels. So, you know, there'll always be a designated reviewer for kind of, you know, scrutinising that PPIE. And I think it is becoming easier to detect those kind of copy and paste PPI things that people have done. And I think people are getting savvier at kind of saying, you know, actually, what, because people just, there's a lot of stock phrases that people trot out in these things, and I have seen more and more feedback saying, okay, but which groups are you going to, who are your contacts and that kind of thing. So, and again, as you pointed to, NHR are driving this, that kind of approach. So I do think it's positive, and I think that, I think we do need to move away from that tick box exercise of just, oh, well, it worked in their application, let's just put the same thing in ours.
So if you could give one clear message to funders for what needs to change, what would you say that is?
So I think a few things. So I think that that funders are very coming on quite strong with this message that they want to see more inclusive research, but I think it is that I think that they may need to make it clear to applicants that they need to kind of they need to have the specifics, they need to show they have an actual plan thought out to do it, and it needs to be kind of aligned with the whole project as a whole. And the PPA is not just at one stage, it's throughout, but also it's in the impact of the research as well. How's it going to impact people? And I always have that picture of that that thing of kind of where you've got the three people stood in front of a fence, and that kind of inequalities, and how is the impact of your research not just going to be the same for everyone, but actually help those with the greatest need the most.
Yeah, that's great. And I think from my point of view, the other thing is for the funding bodies to be much more aware of who is applying for the research, to be much more transparent in the data, because until fairly recently, like RDS didn't collect data about who was approaching them for support, who was then going to put in applications, and then who were being funded. So it was really difficult to see that. And as we encourage greater diversity amongst researchers, and particularly in the area that I'm in clinical academic research, it would be really good to see greater diversity, not just amongst medics, but allied health professions and nursing staff, and also carer and service user led research as well, and for that to be reflected in who sits on those funding panels. So the people who can maybe see through the well-written PPIE to how it's actually going to work in real life and the impact it's going to make. Because I think you're absolutely right. If it doesn't change anything, we'll still be having similar conversations in another 50 years, won't we?
Absolutely. And I think that's kind of like, why keep going kind of, doing mental health research. And I think that's one of the things for me that, and maybe it's, the health economist in me talking, but, I hate to see waste. And I think that bad research just wastes millions of pounds, whereas good research could potentially save millions of pounds. And that's what I think, kind of, again, from coming up with the ideas to executing the study to kind of how you make that difference. I think, it has to be kind of, robust at all those stages to make sure that that end point, is helping those who need it the most. And it's, it's fair and equal.
Yeah. And I think then the next part of it is the evaluation, the monitoring and evaluation of that, because I think that's often missing. So we have fantastic research, in psychology, some great interventions, but really poorly implemented, really patchy across the UK. So family intervention, the one I mentioned, NICE recommends it, but it's not very well implemented. There's some whole areas where there's no family intervention, and so it's really you're putting all of this money into research, but it's actually not changing the services. So, but a lot of the funders won't fund evaluation, they won't fund monitoring, and so who's going to do that then in a way that's really meaningful, that's able to demonstrate the impact that you spoke about? And I think that may be something we need to look at again. So it's been great talking to you. I really enjoyed our conversation.
Yes, you too, Dawn. Thank you.
Thank you.